Good afternoon. I'm Dr. Melanie Royce, a medical oncologist from the FDA. Thank you to the symposium organizers for this regulatory workshop and the invitation to participate in it. My topic is on the regulatory insights on the approval of abemaciclib for hormone receptor positive, HER2 negative, early breast cancer. As a background, hormone receptor positive, HER2 negative breast cancer is the most prevalent of all breast cancer subtypes, representing approximately 70%. It has a long natural history and when diagnosed early is quite curable. However, there are several factors that contribute to high risk of relapse. These include multiple positive lymph nodes, large tumor size, histopathologic grade, high proliferation rate, in part measured by Ki-67 index score. The latter is somewhat controversial because of the non-uniformity in how it is assessed. After definitive local therapy, the mainstay of treatment is endocrine therapy, typically taken for several years. Despite optimal treatment, approximately a third of these patients at high risk will relapse and eventually die from metastatic disease. Thus, more effective therapies are needed. Recently, abemaciclib has been added to the treatment armamentarium. We are well familiar with this drug because it is a CDK4/6 inhibitor already approved for the treatment of hormone receptor positive, HER2 negative metastatic breast cancer. The approval of abemaciclib in the adjuvant setting is based on the Monarch E trial, whose design is shown in this slide. After definitive local therapy, patients with hormone receptor positive, HER2 negative, node positive disease were enrolled in two cohorts. Cohort 1 were patients whose high risk were defined solely by clinical pathologic features. That is, they must have 4 or more positive lymph nodes, or 1 to 3 positive lymph nodes and one other high-risk feature, which could be grade 3 disease or tumor size 5 centimeters or greater. Cohort 2 were patients whose high risk was defined by N1 disease and high Ki-67 score. That is, 1 to 3 positive lymph nodes and a Ki-67 score of 20% or greater assessed centrally. Over 5,600 patients were randomized 1-to-1 to either Arm A or Arm B. Arm A consisted of standard endocrine therapy of physician's choice plus abemaciclib at 150 mg twice daily, given for 2 years. Arm B was standard endocrine therapy. Endocrine therapy was given for at least 5 years, but could continue up to 10 years if medically indicated. To have a better regulatory insight into the approval of abemaciclib, one must have an understanding of the study endpoints and analyses in Monarch E. Represented in this slide is the CONSORT diagram of the trial population, and I have specifically highlighted 3 boxes that will correspond to the population involved in the hierarchical sequential testing strategy that was utilized in Monarch E to control for type 1 error rate at a pre-specified alpha. The primary efficacy endpoint is IDFS in the intent to treat population, represented by the red highlighted box in the CONSORT diagram. IDFS in the Ki-67 population is a key secondary endpoint and was tested in cohorts 1 and 2, represented in the blue and green highlighted box combined, and in cohort 1 only, represented by the blue highlighted box. Another key secondary endpoint is overall survival in the intent to treat population, represented by the red box. Before moving on to the results, note that I have not discussed any other details of Monarch E because those have been presented to you previously at other meetings. In this slide is the Kaplan-Meier curve for the IDFS of the Cohort 1 Ki67 high population. This is the FDA-indicated population. Note that the IDFS probability of those receiving abemaciclib plus endocrine therapy is better than those receiving endocrine therapy alone. The IDFS at 36 months is approximately 86% for the combination arm versus 79% for endocrine therapy alone. Now let's examine why the FDA-indicated population includes only the Cohort 1 Ki67 subgroup and not the intent to treat population. In this slide are the efficacy results of the first interim analysis of overall survival with a cutoff date of April 1st, 2021. I'd like to draw your attention to the row representing the hazard ratios. When we look at the hazard ratio for IDFS in the intent to treat population and the Cohort 1 Ki67 high population, which I will refer to interchangeably as the FDA-indicated population, these are both below 1, which is favorable. However, this is not the case when we look at the hazard ratio for overall survival. Although it is below 1 in the FDA-indicated population, it is not so for the intent to treat population. This is above 1, which may signal a survival detriment. Now granted, overall survival is immature as shown by the very few number of events that have occurred. FDA, however, interprets this as a potential safety signal and thus played a role in our regulatory decision on the approval of abemaciclib. Analysis of overall survival is presented here as a Kaplan-Meier curve. The tables within the curve recapitulate the same information on overall survival presented in the previous slide. Within the Kaplan-Meier curve, the red lines represent arm A or abemaciclib plus endocrine therapy. The black lines represent arm B or endocrine therapy alone. The duration of abemaciclib treatment is represented as a red bar in the horizontal axis of the graph. Focusing on the intent to treat population, we note that during the abemaciclib treatment, the lines overlap. However, the lines separate thereafter with the red line falling below the black line. In the Cohort 1 Ki67 high population or FDA indicated population, we note that although the curves mostly overlap during the abemaciclib treatment, the red line never falls below the black line. How about safety? Well, overview of safety in Monarch E is presented in this slide. The most common adverse events with abemaciclib plus endocrine therapy included diarrhea, infections, neutropenia, leukopenia, fatigue, nausea, anemia, and headache. This is a similar toxicity profile that we've seen with abemaciclib in the metastatic setting. Neutropenia, diarrhea, and fatigue accounted for abemaciclib interruptions, reductions, and discontinuations. Fatal adverse reactions occurred, including diarrhea, which is one of the toxicities well known to be associated with abemaciclib. Revisiting the FDA approval, the indication is as follows. Abemaciclib is indicated in combination with endocrine therapy, either tamoxifen or an aromatase inhibitor, for the adjuvant treatment of adult patients with hormone receptor positive, HER2 negative, node positive, early breast cancer at high risk of recurrence, and Ki-67 score of greater or equal to 20% as determined by an FDA-approved test. Along with the approval of abemaciclib, the FDA also approved a companion diagnostic for Ki-67 assay. This slide summarizes FDA's regulatory decision-making in the approval of abemaciclib. On the left-hand side of the slide is the hierarchical sequential testing strategy utilized in Monarch E. We know that Monarch E met its primary endpoint. Abemaciclib plus endocrine therapy demonstrated a statistically significant improvement in IDFS in the intent-to-treat population, this group. Disease-free survival such as IDFS is viewed by the FDA as meaningful towards the regular approval of a drug, provided there is no overall survival detriment. We also know that overall survival in Monarch E is immature. The hazard ratio point estimate in the intent-to-treat population for overall survival is above 1. This signals a potential survival detriment in a potentially curable population. Therefore, for now, abemaciclib plus endocrine therapy cannot be indicated in the intent-to-treat population. So, among the pre-specified subgroups in Monarch E, is there one where the benefit risk justifies approval of abemaciclib plus endocrine therapy? So first, what are these pre-specified subgroups? One is the Ki-67 high subgroup, which include the cohort 1 Ki-67 high and all of cohort 2. IDFS is statistically significant and overall survival hazard ratio point estimate is below 1 in the Ki-67 high subgroup, this group. But data for cohort 2 is immature with limited number of patients and events. Therefore, the added toxicity cannot be justified for the cohort 2 subgroup. This leaves us with cohort 1 Ki-67 high subgroup. We know that the IDFS benefit is driven mostly by patients from the cohort 1 Ki-67 high population, and the benefit risk is therefore acceptable in this subgroup. That is why the FDA's indication is limited to the cohort 1 Ki-67 high subgroup. In conclusion, Monarch E was the basis for the approval of abemaciclib in early breast cancer setting. Abemaciclib is the first CDK4/6 inhibitor approved in the adjuvant setting and the first agent approved in almost 20 years to treat hormone receptor positive early breast cancer. There are remaining uncertainties. For instance, will the overall survival turn positive in the intent-to-treat population in Monarch E? If so, when and what will be the absolute gain in overall survival? Will the early institution of CDK4/6 inhibitors such as abemaciclib change the natural history of this disease? Will there be new resistance mechanisms? And what are the implications for frontline treatment of metastatic breast cancer? Lastly, I would like to acknowledge my colleagues at the FDA, especially the individuals listed on this slide. This concludes my talk. Thank you very much for your attention.